So thank you all for a wonderful panel. It was just really informative and illustrative, and my head is reeling, though I haven't heard about swim in the soup before. In my world, we call it eating your own dog food. So thank you for that. One more thing that I learned, an analogy I can use in class, but it's kind of, there's so much opportunity and so many different challenges. And I think we would probably disagree on what the end state looks like. And one of the things you learn in the technology business is there really is no equilibrium. It just keeps advancing, at least in our foreseeable lifetimes. The question that I have for you is, if you think about the value chain for healthcare, everything from maintaining good health when you're young to all of us invariably confront kind of issues around health as we get older. So there's prevention, there's monitoring, there's after hospitalization care, there's prescriptions, medicine, medical management, whatever you want to call it, all of these different stages in the value chain. And then you've got all of these different kind of innovators and innovations attacking the market from different points of view. And then we talk about this ecosystem that we need to build. One of the things that we haven't touched on is the dynamics by which we expect this to happen. So where do we see kind of like the first big change, and how will this play out? Kabir, let me start with you.
Sure.
Sorry, putting you on the spot right there.
Sure. I think based on where we see, it always starts with complex care and then moves more towards prevention. So when you look at the market today, especially grandma and that population, the aging in place population, as well as people who have the highest claims that they cause, as well as hospitalizations, those are the ones that need early or very continuous intervention. So we see a lot of technology and dollars that are already being spent into that population be diverted towards technology, and that's when organically it'll flow to the prevention.
Michelle?
Yeah. Well, it's interesting, right? I think a lot of the focus has been in that area. One thing I'm excited about, and one thing we're doing at WellTalk, is if you think about the population, right, you have 15% of the population are patients, right, and get sick care, and 85% of the population are consumers of healthcare, right? And they are in the system, 0.05% of the time or whatever it is. And so we actually see a big opportunity to focus on the 85% of people who are consumers and focus on preventative services and move a little bit towards clinical, right? You can do diabetes prevention and other things, but in a way, I almost see that as the low-hanging fruit, right? I mean, you have all of these people who are using these technologies and they're relatively healthy, and so I actually think it's pretty interesting to start there.
Okay. Stephen?
So I agree with what Michelle said, and prevention would be great. The challenge is prevention, when we think of it, is really behavior change. And people who are fat and inactive already know they're fat and inactive. And giving them a Fitbit to do that, or giving them an app to track their diet is not gonna be enough. And so, I mean, I think that prevention is something that we need to do, but I don't think it's as simple as, we look at how fat we've gotten since the 1970s. It isn't like a whole generation of Americans decided to make bad choices. I mean, we've changed the environment so that we sit on our butts all day, where, we have vending machines full of crappy food. We have less time for lunch. We have meetings during lunch, so we grab whatever we can eat. And schools have gotten rid of gym classes and everything else. And so it's an environment problem that mobile technology is not going to help take care of. And I agree with Kabir that that taking the complex care is a good start for mobile health, but I think that those are going to be these small niches that, and I think that incremental changes in healthcare, so just saying, okay, we're going to start taking care of all our hypertensive patients with mobile technology, and next we're going to take care of our diabetic, is not going to work. I think that healthcare, the way we deliver it now is, for lack of a better word, so screwed up that you just can't incrementally add little mobile health solutions into it, that I think you really need something disruptive. I think that you need, and not to overuse that term, but I I think I would like to see it coming out of a healthcare system, though I'm not confident it will, but I think a really forward-looking healthcare system is going to need to build a model clinic and saying, we're going to build this, we're going to do a primary care clinic that totally ignores all the financial incentivization currently available. We're going to build it from the ground up. We're going to take advantage of the technology that's available. We're going to actually design this around the consumer and not around the physician, the way most healthcare systems are designed, and we're going to show the rest of the world how to do it. That's what I'd like to see happen.
Wow, that would be great, to disengage the reimbursement from just taking good care of people. So I think that one of the main things that we need to do, like you said, just a starting point, and I think thankfully the UCs have moved this direction, is much more openness and porous membranes to the walls around the university, to industry academic partnerships, partnerships with foundations, partnerships with other institutions that are doing this type of work. And we've intersected with every institution up here, but I think that is so important, is to, if you can in some way, even though people do want to commercialize, make money, if you don't make money, it's not sustainable. If it doesn't work, it's not sustainable. So we have to think in terms of sustainability, but how can we find ways to align our incentives? And I think the more we focus on trying to do that cross-disciplinary work and finding those alignments, I think we're going to move things a lot faster. A lot of the things I talked about are technical needs, but I don't think that's what's rate limiting. I think it really has to do a lot with incentives and aligning incentives, even down to self-management. It comes back to that.
Michelle?
Yeah, I did want to make one more comment, and I agree with you. I think, my father is 100 pounds overweight. He's been over 100 pounds. He's been 100 pounds overweight for as long as I can remember being in high school. I can tell him to do things. He will not change. You know what's making him change now is the fact that he is now more responsible for his health care, and he's paying more out of pocket, right? And that's why I think, some of the trends. One is incentivization and the other is personalization, right? So the more individuals now can tie, if I do this activity, I get $100 off my copay, or sorry, my premium, right? Or I get $10 off my copay this month. I really think we're going to see that driving change. So there's incentives. And then the other thing is personalization, right? That's why I'm excited about cognitive computing, because usually when someone tells me to lose weight, it's do these same 3 things, right? But they're not taking into account my individual health status, where I live, what my interests are, what my health plan is, right? And if you can pull all that information together and really personalize the activities you want me to do and then incentivize me, I think you will see more consumers changing their behavior.
I also think that one of the things that you're talking about with personalization is where we're working a lot more with design thinking, because there are some principles around that of really getting to know that person and what drives that person and what incentivizes them. It might be the fact that they're now taking care of their grandchild, so they want to live longer. It's finding out what the drivers are for people, and design thinking brings that in very early.
And I love the idea of this startup that is actually, to Dr. Steinhubel's point about kind of who can demonstrate the value of an integrated healthcare system built from the ground up using kind of what's available as to today and not constrained by so many of the technology and kind of incentive challenges that we face. But with that, let me turn it over to the floor for questions to the gentleman over there.
Yes, thank you very much. It was a great panel. But I want to ask more about the costs and the impact on the costs of care, because this is a pretty serious decade we're facing with really serious interest in reducing the rate of growth of costs. And I didn't really hear much from the panel about how you think this is going to ultimately lower that rate of cost. You've talked about value, but it was more on the, the impact of improving health, which sounds like there's still a lot of work on the efficacy side. So can you address more specifically how you think this is going to really help reduce the rate of costs and yet at the same time improve quality? Thank you.
Just some of the things that many of our partners are doing include choosing between having someone spend $8,000 a night in a hospital bed versus being monitored at home. And so we're seeing a lot of programs where it's not just about grandma being the user in this, it could be the caregiver. We see a lot of examples today where many of us have home security systems at home where we're making sure there's no intruder coming in and the house is safe. Analogous to that, there's almost like a peace of mind service that we're starting to see, where lots of caregivers are working with their elderly relatives just to avoid that additional cost of having to hospitalize them and actually make sure that they remain healthy. So the aging in place and the remote patient monitoring use cases we're seeing as a really good way of reducing the hospitalization.
Projections of what we could expect?
The projections vary, but I think the goal for us is really to organically see where the market goes. So for right now, we want to continuously enable the right use cases, but both from the payer side as well as from the provider side, we're starting, especially with the ACOs and the readmissions, we're starting to see lots of use cases. But in terms of projections, both the transition care and aging in place, those are the two use cases we see really becoming predominant in terms of lowering healthcare costs.
I can give one specific example. So there's a company, Propeller Health, which I actually mentioned. I'm actually on their advisory board as a disclaimer, but they are the company that puts the GPS devices on the asthma inhaler, right? And it's early days, and I think this has been publicized, but they've done a project with Dignity Health focusing on the Medicaid population. And so far, they've shown savings between $8,000 and $10,000 per year per asthmatic patient in their Medicaid population. So I think you're starting to see some real tangible cost savings. I don't know how that will project out, but that's what I want to see from these devices, right? What is the ultimate impact?
When I talk about effectiveness studies, I always talk about two categories. One is the health outcome, and one is the cost effectiveness. That's an effectiveness study. And every single startup pitch has a slide for you in it. But what they haven't done is connect the dots between their projected savings and does their device actually translate to that, because it's early, and it wasn't built into the development equation. But I do think absolutely that has to go hand in hand when we're looking at effectiveness. It's effectiveness on health and effectiveness on the healthcare system, the cost. I think there is much promise if we can keep people out of the high acuity zones where that is preventable, where we know that if we do better maintenance care, or even early on prevention, but better maintenance of the disease situation, we can prevent this episodic crisis care, which is extremely expensive. That's what leads to the ER visits, that's what leads to the hospital stays, the surgeries, $35,000 minimum for a hip fracture, when if we put in safe mobility and patient monitoring systems outside the system in the highly distributed model, we can actually prevent some of those high acuity events from happening. Those are easy to put price tags on and model.
Just the last statement.
For monitoring and preventing falls? Yeah, we don't have that technology yet. Most fall technology monitors after the fall happened. It's accelerometer based, but we're actually working with some technologies that will detect moving outside your center of gravity and riding. And so there are some very early stage things going on that are actually truly about detection. Simple ones are bed alarms. Is the patient getting out of bed? You know, and it's a patient who's not safe. But as far as fall detection, it's too late if they've already fallen, and that's where most people target their fall prevention systems. So you're right, absolutely.
I just had one.
Go quickly, go ahead.
One more comment too. I know everybody asked about cost, but one thing I think we should keep in mind is I think there's a higher level way of thinking. So there's cost, right? But there's also health status. And, you know, Jeff Margolis talks about in his book, right? Should we be thinking more about healthcare value, right? Which the equation is really healthcare status over cost. So you can move either part of that equation. So we can focus on cost, which we should, but let's also focus on improving healthcare status, because that overall improves healthcare value in the system.
Great. Let's take a question over here.
So my question is regarding EMR, the legacy systems, and I'm wondering if what you think, first of all, their strategy is now, because I see them becoming a commodity eventually, and unless they get in the game. And I'm just wondering, because it's hard to penetrate, and they're the holder of the data, which is the holder of the power. So I'm kind of curious to see if anybody has an opinion on what their strategies are right now, the large ones.
I live and breathe one every day because I'm also a clinician as well as working in innovation. So I think their strategies started out, it was a billing system. It was a billing and then a legal system, and it wasn't ever designed for, at least the older systems, for improving care. So it's a little outdated just in the framework, but that's changing rapidly, and I think new systems are coming out that are completely going around the big giants, and there are several examples that you're probably already aware of. Besides that, there's a ton of information outside the clinical care system that I think is going to be extremely valuable in self-management and overall population management. So it's important to get that information back and forth. I spent quite a bit of time on talking about it, but that's not all there is. So the other piece of it is they are really feeling the pressure. So we had a meeting with the Epic Innovation team just a couple weeks ago. There will be some API capability around Epic. Now, mind you, you have to, when you get data in or out of Epic, getting it in, it has to be changed in format. The analytics have to be done, algorithms have to be put on it, or you're just pushing data in, either in structured or unstructured ways that will not be actionable because it's not going to sit in any meaningful place. The EMRs are like Home Depot of clinical data. That they are really not very functional unless you get data to the right place in the workflow where a person who's going to see it can take action on it. So I think it's really important to know they're going to have some API capability. They're feeling the pressure, so that's coming. And they're looking more at how they can be more collaborative in the process of doing the work. They're not very good at that either, but they're feeling the pressure because so many innovative people are doing things outside and around them.
So let me add my answer to that one. This is a platform-based world. And I think the optimal play for an EHR player is to become a platform. I think if you really think about that's the person who's going to win. When I think about my iPhone or my Android phone, what are they really about? You always ask, the question I like to ask is, how many products of this, actually let me ask you the question, how many products of the Sony Walkman disrupt? You'll look at me like I'm crazy, right? Can you name one? How many products did this disrupt? 1,000, more, right? It's a GPS, it's a music device, it's a movie device, it's my email, it's my text messaging, it's WhatsApp, it's interoperable, that's why WhatsApp is so successful. But what is it? This is a platform that leverages a whole bunch of stuff. It is the ecosystem, it is the content provider, it is the ecosystem, it's built all these relationships together. So when you start integrating mobile with EHR, the company that gets it right is the company that's going to win. And you know, APIs is a big piece of the story. Kabir looks like he's anxious to add something.
Yeah, I think I just want to add to that is I don't think it's an either or, meaning do the Epics of the world win or do the rest of the ecosystem win? It's all about fluid data, and it's making sure that as a user or as a patient, I have access to that, and then there's an opted-in community that's decided to visualize that. So I envision the EMRs of the future will just be one instantiation of my data, but there's multiple nodes from where I can see the data. So data is no longer going to be locked in one place. It's more fluid, and then APIs just act as the tunnel to get that to
So I will take a little bit of issue with that. We got to make it exciting towards the end of this. So let me ask you, how many car companies are there in the world? 75 or so. 50, many of them in China. How many database providers are there in the world? Big data, 3. How many map providers are there in the world? 2 to 4, right? So when you start looking at information-based products and software-based products and services, what you invariably find is what we economists call the winner-take-all economy. And what you really have is a very small number of places. So you have this brutal competition for the first years of an industry. Then it settles down. Look at operating systems. You know, there aren't that many. It's Microsoft and Google and a few others, right? So you start putting this picture together, and I think because your question originally was, what is the strategy for an EHR provider or an EMR provider? And I think there'll be a handful of them left standing in a few years because of the economics of the software business. But let's who has over there?
Hi, my question has to do with data security and privacy. As an example, when I do online banking with B of A, I know where my data is stored, right? I know that my financial data is secure. I haven't heard any discussion about data security and privacy. But, so if we think about HIPAA, being protected, being passed to protect our privacy, it's important for us to know that this information can't be hacked, that insurers can't use it against us to raise our premiums, et cetera, et cetera. So data security and privacy.
I'll jump in on that one. So there are standards, and what's happened now is that most of the startups who are working with any kind of PHI know that they have to say they're HIPAA compliant or HIPAA secure. So there's a lot of online information and boxes are being checked. But to be honest, if you're really going to have a HIPAA secure system, you need a third-party audit and an ongoing monitoring system. So again, it's something we're trying to educate about. I think the truth is we traded away security for convenience a long time ago in banking, and it's happening also in healthcare, and we have to figure out where's our societal consensus around that. And we're not quite there, so people are still being penalized and fined for things that happen that aren't even our fault, but it holds a standard which we should hold, which is protecting people's information. We don't have protections against people biasing us for jobs or for insurance, although it should be, if we have health conditions. So those things society doesn't have a consensus around either. So we have to hold to the highest standard of security and privacy that we can, and it's a constant thing. It's an ongoing process to continue to monitor that, and we need to educate all the creative individual people building things of what that is, how do you do it, just like the FDA. These are necessary but challenging things we need to deal with.
And I think the legitimate companies are the ones who are going to treat privacy and security as differentiators rather than as a crutch. And so we see a lot of partners that tout the fact that there are levels of security that in some ways HIPAA is a guideline, it's not a mandate. We see a lot of when you look at the credit card industry, there's the PCI, the payment card industry compliance. Those levels of security we are starting to see across the board, including how we do it in Qualcomm. The goal's always been let that be a table stake so that it doesn't become part of the conversation, because if it does, it's more to say that that's a differentiator versus a.
Let's take the question over here.
This is by Dr. Sawyer. You briefly mentioned blue button, and my understanding that's part of the meaningful use criteria. Can you explain a little bit more about what blue button's about?
Yeah, I'm not an expert on it, but I'll take a stab at it. So the federal government has really tried to encourage people to share data more and into a common platform so that patients and other entities, et cetera, researchers, other healthcare systems can use it. So they're trying to enroll people and encourage people building technologies to allow their data to be consistent with the platform of Blue Button and to pass into it. So it's really worth looking at. It's a standard that's actually getting a lot more adoption. I think you probably have devices and screen for that because that will lead us more and more towards interoperability. Yeah, they actually have a blue logo. It didn't, for some reason, show up. It was on one of my slides. But the ONC is a good resource in the federal government to look that up. They're also pushing to get, it's like the Open Health platform. You have to have common standards and formats to make all that work. So they're actually pushing that part of the envelope as well.
Great. Let's take a question over there.
Yeah, Larry Wellickson, CEO of the Society of Hospital Medicine, where the average age of our 44,000 hospitalists is 37. But I'm very impressed with all the technology, but my concern is the rapidity with which this will be available as short as 2020 is breathtaking. But I'm very worried about, and I'm not worried about the consumers, even the fat, lazy ones. But the institutions that worry me are that we are not selecting the right physicians to come into medicine, and that our academic institutions are not making the workflow changes that need to be made now to anticipate these developments. So think about the fact that you have the doctor that's trained basically the same way they were in the 1970s. You're still recruiting soloists in a world of team and information integrators. And now I'm sitting there in my office and I've got every heart rate and every blood pressure reading and every blood sugar reading, and I don't know how to change the way I do things. So, we're sitting in an academic institution that seems to be more innovative than maybe its peers. But, do we have any hope that when we finally get all these great tools and the patients have them, that our healthcare system and our academic system is preparing people to use this.
Stephen, do you want to take that one?
Yeah, I think we're way behind. I think it's a great point. And one example is I showed a very quick picture of a pocket ultrasound. And, when I was in medical school, you're taught the physical exam, and you go through all those details. And if I want to know how big the liver is, I palpate and I push on it. We have you can, instead of a stethoscope to listen to your heart, you can just put an ultrasound on it and hold it in your pocket, and you can look at the heart. You can not only, hear a murmur, you can see what it is and see if it's dangerous, to see if something else has to be done. You can look at the carotid arteries. You can look and see their hydration status, their jugular veins. You can look at their thyroid. You can look at the liver, the spleen. There are 3 medical schools that have started teaching their students how to use ultrasound. Only 3. And then we're graduating a generation of doctors who don't understand genetics. Most practicing doctors right now don't understand genetics, but you've got 23andMe, or you used to, you will again, who used to, so patients would come in and say, this says my risk is this. Most doctors have no idea what to do with that. And still most schools are not teaching. We're still dissecting cadavers where we should, and I'm stealing this from Dr. Topol, we should be dissecting our own DNA, and that is really true. And in the information, we're still taught, doctors are still taught as kind of the master builder of old, and I'm stealing this from Clayton Christensen, of, where I'm the master of everything, I understand everything. There are 20,000 articles published every week, peer-reviewed medical articles published every week. Your doctor, no matter how smart you think is not keeping up with that, and that's why it takes decades to change. And we're not teaching doctors to be more we're still teaching doctors to memorize everything, know everything, and when you graduate. So I'm amen to you. I think there needs to be a huge change. If you know anybody who'd like to start a medical school, we'll help you get a really innovative.
On that note, IBM is actually training Watson to pass some of the medical boards now, which I think is, for those of you who think cognitive computing isn't happening, it is real. But and this is serious, and because the chess stuff is easy, Jeopardy is easy, and to your point about 20,000 medical articles, only a machine can keep up. We have time for one last question. If you could keep it short and we could keep the answers short, that would be great.
Yes, thank you very much. I'm William Bonney, Bill Bonney, HealthCare Council of Orange County. And previous questionnaire actually almost overstepped what I wanted to say. Your presentation is just extremely stimulating and telling us all of the resources that will be coming our way very soon. And the question is how to implement this in daily practice. In other words, how to sell this to physicians who are so busy. Here's this wonderful industry up here, and here are the physicians over here. We're just examining patients and too busy. And so one of the strategies is going to be, it's so important to sell this to physicians, to use medical conferences to sell them and show them how it makes their care more efficient so that they will have more time for the doctor-patient relationship.
Thank you. If one of you could just give a quick answer, we need to.
We're involving them in the equation of innovation. So that's partly, it's informing what's being built and how it needs to be built to be able to be used. Our hospitalists are our busiest group of innovators in our hospital. And so part of it is get them involved in the equation, but make sure you really understand what their pain points are so that you're addressing their pain points and it fits in their work.
Really quickly, doctors will do it if they get paid for it. And so I think the best way is to, in the ACO world, it's to show that it's outcomes. In the fee-for-service world, to make sure there's actually a payment.
So a technologist who speaks like an economist, I love it. Thank you all so much for being a wonderful audience. Thank you to the overflow room.